Hello, my name is Patrick. In this video, I am going to explain the different kinds of headaches. Hopefully, at the end of this video, you would have a better understanding of which one you struggle with. And if you have a better understanding of which one you are dealing with, it helps you in terms of management. So let's define headache. I know this is a conversation. This is a topic that is fairly familiar with a lot of people. However, anytime I'm having a medical conversation, I like to define what it is that I'm talking about. So what is headache? Headache is pain or discomfort in the head or face. Now, there are different kinds of headaches depending on location, intensity, and how often the headache occurs. So that's the definition of headache. There are two different classifications of headache. You have a primary headache and you have the secondary headache. The primary headache includes tension headache, migraine, as well as cluster headache. And the primary headache is responsible for 90% of all headaches. Then you have secondary headache. In secondary headache, it includes meningitis, subarachnoid hemorrhage, as well as intracranial hypertension, and so on. So again, you know the definition of headache. You know there are two classifications that include primary headache as well as secondary headache. For your primary headache, you have tension headache, migraine, and cluster headache. And then for secondary headache, you have meningitis, subarachnoid hemorrhage, and intracranial hypertension. For this video, I am going to concentrate on the primary headaches, starting with tension headache, which is the most common type of all headaches. So again, the most common type of all headaches is tension headache. So now you know that. My question to you is, how is a patient going to present? So what will make you say, okay, this patient has tension headache? The patient is likely going to complain of band-like discomfort. They're going to describe this headache as if a rubber band was tied around their head. So that's how they're going to describe it, as a band-like headache. The pain is likely going to be generalized. It's going to be steady and achy discomfort that is non-pulsatile. That's very critical. Okay? Again, they're going to complain of band-like discomfort with a generalized pain. It is steady and aching and it's non-pulsatile. And as we progress in this video, I'm going to expose you to the other kinds of headaches, and that will help you make the distinction. So patients with tension headache, they typically do not have problem with light, sound, nausea, or vomiting. Okay? So now you know what a tension headache is, and you know how the patient is likely going to present. My next question to you is, what are the risk factors? What are the things that can predispose you to tension headache? Number one is stress. If you have had an opportunity to listen to my previous videos, you probably would have heard me say that at the center of most medical problems is stress. So stress is one of the risk factors. And I always tell people there is nowhere you can completely eliminate stress from your life, but you can definitely do a good job of minimizing your exposure to stress. So stress is number one. You have sleep deprivation. And for those who like to go to bed at 2 a.m. in the morning, this is for you. It is time for you to turn off the TV, turn off your phone, and get some sleep. Sleep is very important. Straining constantly straining your eyes, looking at the computer, looking at your phone, watching the TV, that will more than likely predispose you to having a tension headache. Another risk factor is trauma. If you have trauma to your head, if you have trauma to your neck, that can be a risk factor. Another risk factor could be increased neuronal sensitivity. Another thing that can predispose you to tension headache, and this is it can be secondary to muscle contraction. Okay? So now you know what it is. You know how a patient is likely to present. You know the risk factors. Next question is, who is most likely to be affected? Women are mostly affected by tension headache. Okay, women and those who are in their mid-30s are mostly affected by this type of headache. All right. So my other question is, how then do you diagnose tension headache? So you know what it is, you know the people who are mostly affected, you know how it's likely going to present. How do you diagnose it? It's not enough for you to know what it is, but you have to be able to make the diagnosis, right? So tension headache is clinically diagnosed. Now you can do other labs, you can do labs to rule out concurrent illnesses, right? But there's no lab that you're going to run and it's going to tell you, oh, this person has tension headache. We don't have that. So this is where you earn your money as a clinician, as a provider. You have to use your medical knowledge to figure out what it is that the patient is having trouble with. So you make the diagnosis clinically. And when you do physical examination, it's usually going to be normal, right? But the patient might have tenderness on their temporal region. They may have tenderness on their head. There could be tenderness on their neck and their shoulders and so on and so forth. But normally you make this diagnosis clinically. So you've been able to make the diagnosis. Then the next step is, how do you treat it? How do you treat tension headache? You treat this by giving analgesics. So the first line treatment of tension headache is analgesics, such as aspirin, acetaminophen, or NSAIDs. And if that is not effective, you can try anti-migraine agents. Another thing you can try is intramuscular ketorolac. And you can do local heat and muscle relaxants. Okay, so again, the first line treatment of tension headache is analgesics, such as your aspirin, acetaminophen, or NSAIDs. If that doesn't work, you go to the next line, which is your anti-migraine agents. If that doesn't work, you can do things like ketorolac. You can now do like heating and muscle relaxants and so on and so forth. So that's with tension headache, right? We have been able to deal with that. The next type of headache is migraine. So migraine is the next type of headache that I'm going to talk about, and these patients are going to come in with a unilateral throbbing or pulsatile discomfort that is often associated with nausea, vomiting, photophobia, as well as phonophobia. Photophobia is fear of light. Phonophobia is fear of sound, right? So you can already see the difference. In tension headache, with tension headache, we saw that the patient came in with a band-like discomfort, that the pain was generalized, non-pulsatile. It was bilateral pain, like a rubber band that was tied around their head. But in terms of migraine, okay, it is pulsatile. It is unilateral, right? And the discomfort is often associated with nausea, vomiting, photophobia, and phonophobia. Phonophobia is fear of sound. Photophobia is fear of light. Okay? And migraine headache usually lasts between 4 and 72 hours. And it is worse with routine physical activity. Okay? So that's the distinction between the two. Now, what are the triggers of migraine? Number one, well, not number one, but one of the common triggers of migraine is chocolate. I know you love your chocolate, right? But if you have a history of migraine headache, you probably want to stay away from chocolate. Another one is red wine. Another one is hard cheese. Another one is stress. Lack or excessive sleep. And that's an interesting one. I don't know how many of you have noticed this. This has certainly happened to me, right? As well as we love sleep. Have you noticed that sometimes when you sleep excessively, you actually start having headache? That has happened to me. So another thing that can trigger migraine headache is dehydration. Another thing is hormonal change, right? Hormonal change, such as oral contraceptive or menstruation. And that should cue you in. That should make you think that the people who are most likely going to have issues with migraine are women, right? Because this is a kind of headache that follows menstrual cycle pattern. So women are more likely to be affected by migraine headache compared to men. And this is also in migraine headache, it is important that you ask the patient about their family history, because 80% of patients who present with migraine headache are going to have family history. So this is when you want to ask, does anyone in your family suffer from migraine headache? Your mom, your dad, anyone in your family who suffers migraine headache, because this kind of headache has association with, it has a link to family history. All right. So now you know what a migraine is. You know how the patient is likely going to present. You know what the triggers are. You know who is more likely affected, right? So the next question is, what is the pathophysiology of migraine headache? I'm telling you now, they love to ask this question. Okay? For those of you who are, taking your exams or whatever it is, right? They love to ask this question. What is the pathophysiology of migraine headache? It is attributed to intracranial vasospasm, followed by extracranial vasodilation. I'm going to say it again. It is attributed to intracranial vasospasm, followed by extracranial vasodilation. It is also attributed to trigeminal nerve dysfunction. Okay? I believe that's the cranial nerve 5, the trigeminal nerve dysfunction. Now that you know the pathophysiology, what are the two types of migraine? So there are actually two types of migraine, right? You have migraine with aura as well as migraine without aura. So you're probably wondering, what is the difference? Here is the difference. So the migraine with aura, the patient is going to have, in addition to headache, the patient will also present with visual changes. They will have flashing lights. They can also have floaters, right? So there will be visual changes in addition to the headache that they are having. And they may also have transient neurologic deficits, as well as hemisensory loss for less than 1 hour. Okay? Then migraine without aura, that is more common, right? In terms of migraine, the migraine without aura is more common, and it's usually accompanied by nausea, vomiting, photophobia, as well as phonophobia, and the duration is between 4 to 72 hours. That is the distinction. All right, so you know the migraine. You now know there are two kinds of migraine, the one with aura and the one without aura. You know how they present. The question is, how then do you diagnose migraine? Just like I mentioned with tension headache, migraine headache is clinically diagnosed. There is no lab that you're going to do or no testing that you are going to do and it will say, hey, this person has migraine headache. You are going to have to figure this out clinically. And when you do physical examination, it is usually normal. However, you may see things like aphasia, paresthesias, dysarthrias, or even weakness. Okay, aphasia is when a patient has problem with understanding language and speaking as well. So that's how you make that diagnosis. Now you made the diagnosis, how do you treat migraine headache? You treat migraine headache with NSAIDs, acetaminophen, or aspirin. So if it's mild, right, it's not moderate, it's not severe, it is mild migraine, you can give patients things like NSAIDs, or you can give acetaminophen or aspirin for mild migraine. Okay, but if it progresses to severe migraine, right, if it's moderate to severe, then you can give things like triptan. You can give triptan, and you might also add NSAIDs to it. Okay, so that's how you treat it, right? If it's mild, you give things like NSAIDs or acetaminophen, but if it's moderate to severe, you can give triptan, and you can also add NSAIDs to it. If you have done that and it doesn't work, you can try dihydroergotamine IV, right? You can try dihydroergotamine or IV prochlorperazine, right? I struggle with that. So this is where you treat it. You give IV dihydroergotamine, or you can give IV prochlorperazine, okay? And that will be able to address the headache as well as the nausea. So that's how you treat headache. Another question they like to throw in there is, what do you give to prophylactically treat migraine? So what do you give patient to prevent them having migraine? One of the things that you can give is beta blocker. So you can give propranolol, or you can give calcium channel blocker, such as verapamil, or you can give TCA, which is tricyclic antidepressant. Okay, they like to ask this question: what do you give patient prophylactically for migraine? Again, you can do propranolol, which is your beta blocker, or you can do verapamil, which is your calcium channel blocker, or you can do amitriptyline, which is a tricyclic antidepressant. Okay, so that is that with migraine. So now you know what migraine is. We discussed tension headache, and we have discussed tension headache. We have discussed migraine. The next one is cluster headache. But before I get into cluster headache, there's also another question they like to ask, right? I said one of the ways you can abort migraine headache is to give triptan. So I've seen a situation where they ask, what is the contraindication to giving a patient a triptan? So they always like that question. So the contraindication is this: if a patient has an ischemic stroke, or they have a heart disease, or they have an uncontrolled hypertension, or the patient is pregnant, you want to avoid giving a patient triptan. Okay, so now you know that. You know migraine headache, how to diagnose, how to treat, who is more commonly affected, the risk factors. The next thing is cluster headache. How is a patient with cluster headache going to present? These patients are likely going to present with unilateral. They're likely going to present with unilateral pain followed by ipsilateral lacrimation. Lacrimation is tearing, right? So they are likely going to present with unilateral pain followed by ipsilateral lacrimation, conjunctival injection. They can have nasal congestion. They can have miosis, which is pupillary constriction. And they can have ptosis, which is drooping of the eyelid. Okay, so cluster headache is extremely severe. It is unilateral, and it can have preorbital connection. So it's unilateral, a preorbital headache that is short in duration, and it may even happen several times a day. Okay, so that is cluster headache. Okay, now question for you is, who is likely going to be affected? So in which age group or gender are you likely to see cluster headache? It is common in middle-aged men, okay, who are and middle-aged men, and there's no family link. So there's no family history, as we saw with migraine headache. All right. So these patients, they are always pacing around in the room because the pain is extremely severe, and it's not relieved at rest. So with migraine headache, they want to stay in a quiet environment and they want to turn off the light. But with cluster headache, right, these patients are constantly pacing themselves, trying to find some relief, because this headache is very severe. And even when they are resting, it doesn't relieve the headache. Okay? So that's an important thing to note. Unlike migraine headache, that it can get better at rest. So now you know that. My next question is, how do you diagnose cluster headache? Again, there's no lab that you can do that will tell you, oh, this person has cluster headache. But you can do a brain MRI to rule out other causes. So once you do that, you know what a cluster headache is. It's more likely going to present in males. Okay? The question is, how then do you treat the cluster headache? You can treat cluster headache by giving 100% oxygen. That's the treatment. 100% oxygen, as well as subcutaneous sumatriptan. Okay? That is the treatment. Do not forget that. So 100% oxygen and subcutaneous sumatriptan. So the next question is, what medication can you give someone to prevent cluster headache? So what medication can you give someone to prevent cluster headache? You can give calcium channel blocker, and the one they always like to use is verapamil. Okay, so that is it. Now we're gonna do a little bit of question. Let me see if you understand the different kinds of headaches that I just discussed. So you have a patient who is, 45 years old, and she's a female. She's coming in with episodes of bilateral squeezing headaches that it's always happening 3 to 4 times a week. She's experiencing significant stress in her life. What do you think this is? Right? So this patient is about 40 years old. The patient is a female, has different, recurrent episodes of bilateral squeezing headaches. and these headaches continue to happen 3 to 4 times a week. There's significant exposure to stress in her life. What do you think this is? What is the likely diagnosis? So this is tension headache. Okay? Why is it tension headache? Remember, with tension headache is bilateral. It's like it's like tying a rubber band around your head, right? So this woman, she's a female. Tension headache is more likely in female. She's about 40 years old. She has bilateral squeezing headache that is always happening, right? It's recurrent, right? It's happening like 3 to 4 times a week. And she has an exposure to stress, which is one of the major risk factors, right? So this is screaming tension headache. So question number 2, let's say you have a 20-year-old male who is presenting with headache that is also accompanied with ipsilateral rhinorrhea, so you have a 20-year-old male presenting with this terrible headache that is associated with ipsilateral rhinorrhea. Rhinorrhea is runny nose, right? Ipsilateral means one-sided, right? So one of the noses is running and they have tearing in one eye, right? And the eye is also red. So they have runny nose on one side of the nose, right? And they have tearing of the eye on that same side, right? And they have redness, and they are complaining with headache. They have this terrible right-sided headache, and the right-sided nose is running, and the right-sided eye is tearing, and it's also red, right? And this happens every night and keeps waking him up every night. What do you think this is likely going to be? This is cluster headache. Okay, this is cluster headache. It is mostly found in males, and it comes with periorbital headache, as we have seen. So this patient has runny nose on the right side. The right eye is tearing, and there's redness on the right eye. This is screaming cluster headache. Number 3, let's say you have a 20-year-old female with several episodes of throbbing left temporal pain, right? Throbbing. You need to underline that. So this patient is 20. She's a female, has several episodes of throbbing left temporal pain that lasts, let's say, between 2 to 3 hours. Okay? And before that, she has been seeing having all these visual changes, seeing flashes of light and in her right visual field. And this comes with weakness and numbness on her right side, right? What is this? This is migraine headache. How do we know that it's migraine headache? Migraine is more likely found in females. So females encounter migraine headache more than males, right? So this patient is a female, and they describe the nature of this headache as throbbing. That's the key. Throbbing left temporal pain. And look at the duration, between 2 to 3 hours. And before that, she started seeing flashes of light. So this is not only migraine, this is migraine with aura. Okay? So that's it. I hope this video has been able to explain to you. So now you can be able to tell your friends, you can be able to tell your family members, you can be able to tell anyone that there are different kinds of headaches. Okay, because a lot of people think that, oh, I just have headache. No, you don't. There are different classifications of headache. There are different types of headache, different types of primary headache, different types of secondary headache. Okay? And again, the reason that is important is if you know exactly what it is that you're dealing with, it puts you in a better position to know how to manage it. All right? So that's it. Thank you for your time. Thank you for your subscription. Thank you for always listening. And the goal is to provide you with quality information which will enhance your ability to make the right choice. All right? Stay blessed. Stay healthy. Thank you.